Otherwise, we will just progress as used to. So it's a 58 years old gentleman present with chest pain in the clinic.
When did the chest pain start?
About 5 days now.
I beg your pardon?
About 5 days now.
And whereabouts in the chest is the pain?
So it's just right in the center of the chest.
Okay.
Does the pain go anywhere?
Nope, it's localized.
Is the pain constantly there?
Comes and goes.
Sorry, is that a yes? It's constantly there?
It comes and goes.
Oh, sorry, comes and goes.
It's intermittent.
Does something make it better?
Rest. So when I feel the pain, I just stop doing anything, just rest, and I can feel better.
Is there anything that makes it worse?
Exercise or physical work.
Can you describe what the pain feels like?
It's like a burning sensation.
How long does the pain last?
It may last for a few minutes.
What is your diet like?
The diets, like greasy foods. I prefer greasy food.
How would you rate the pain on a scale of 1 to 10?
It's about 4 to 5.
Before 5 days ago, had you ever experienced a pain like this?
Yes.
You had?
Yes,
When?
yes. So I've always had the pain for a few years, about 8 years now.
8.
Yes.
So 5 days ago, what changed?
Just become more frequent.
More frequent, okay.
Do you experience any other symptoms with the pain, like shortness of breath or anything like that?
No shortness of breath.
And sweating?
No sweating.
And any nausea?
No.
Have you
Are you
ever
on?
had... Sorry.
It's okay, you go.
Did you ever have this pain addressed by another health professional in the last 8 years?
Yes, I went to the hospital and diagnosed as chronic heart disease.
Okay. When was that?
Also about 8 years now.
Are you on any medication?
Yes, but I'm not quite sure the name. Yes, I take it regularly.
Okay, and do you know what the medicine is for?
For the heart condition, coronary heart disease.
So it's not for cholesterol or blood pressure?
No.
Do you have high blood pressure?
Yes.
And you're not on any medicine for high blood pressure?
I do use. I take every morning.
Okay. And for cholesterol?
No.
What about your mood? Are you a person that has a stable mood?
Yes, yes.
Does this pain get worse if the weather changes? Maybe if it's hot
No.
or cold?
No.
What does the patient's tongue look like?
It's like purple and with white greasy coating.
And the pulse?
The pulse slippery.
Is anything noticeable when we look at the patient on their facial complexion?
No.
And what about your level of energy? Are you full of energy? Are you tired?
Nothing special, so it's normal. It seems normal.
Anything unusual about your sleep?
No.
It's okay.
It's okay.
Are you a smoker?
Nope.
Anything unusual with stool and urination?
Also nothing special.
If we take your blood pressure, is there a blood pressure reading?
It's under control now, so it's about 125/80.
Do you have a family history of heart disease?
No heart disease, but hypertension.
Is there anything significant with the respiratory and pulse rate that we can see on physical exam?
No.
No fever?
Nope.
Do you have any stomach problems where you have heartburn or pain after eating?
No.
I can't think of any more questions. I don't know about anybody else.
I also can't really think of anything else.
That's
is
good.
this worse after heavy meals?
No.
No.
Do you do anything when the pain comes, when you feel that pain? than
Sometimes. Yeah,
What do you
some. So sorry, what did you say? You said do anything.
Yeah, do you do anything when that pain comes other than rest? Do you do anything to help with the pain?
Sometimes I take like some tablets the doctors told me can relieve.
Okay. Okay. Are you on any other chronic medication apart from the ones for your chronic heart disease and your blood pressure? Are you on anything else?
Nope. Okay, I'm going to stop here, and you also run out the questions. You also can see from here, your consultation can be complete in 10 minutes because now it's exactly 10 minutes.
Well, that was good then.
So which means if we focus on the topic, the complaints, if you don't like discharged by the patient to talk other stuff, you actually can limit your consultation quite efficiently. So for this case, I want you to just clean up the story of the present disease history and also the diagnosis, the differential diagnosis, and also the plan.
Okay. Thanks, Dr. Hu.
Thank you.
Okay, does everyone agree that this is angina?
Yes.
Okay. And then what about differential diseases for angina? So there would be stomach GERD, which we excluded by asking about stomach diseases. Obviously myocardial infarction, but I mean, this gets better after a few minutes and better for rest,
Yeah.
so it's definitely not that. Do we have another one?
Are we going to differentiate between stable angina and unstable angina?
We could do. I mean, this seems to have been stable and now is slightly more unstable because it's happening more frequently.
Yeah.
I think. It's not very unstable. I mean, it's not. Well, I suppose it is getting worse. So so probably unstable angina, let's say.
Yeah.
Would you agree, Cecilia?
Yes, I would.
Okay.
Um,
Did anyone have another differential? I know we should usually have 3. I just can't think of another one right off the top of my head.
Pericarditis.
Yeah. Okay. All right.
You can say something like an embolism, even though there's no shortness of breath or anything like that. That's the negative
Yeah, that would be
symptoms
why.
that we've got.
Yes.
Yeah.
Okay. Okay.
Yeah.
Right. And so that would be our differentials. Oh, and what about syndrome? Because I mean, there's obviously phlegm because he likes the greasy food, right? So that's improper diet. And if you look at the tongue being purple, there must be phlegm accumulation resulting in blood stasis because of the purple tongue with the slippery coat.
Yeah.
I agree with that, Angie. I think that's a good syndrome.
Is that good? Okay. So we're going to say unstable angina.
Mm-hmm.
And then the syndrome, we're going to, and there's no, it's not like spleen chi deficiency or anything like that because there's no shortness of breath. So I can't really see any heart specifically. There's no cold. So I just think, I would just go phlegm accumulation. Yeah, I don't have a particular organ that I can pinpoint.
Phlegm accumulation resulting in blood stasis.
With blood stasis, yeah. I think.
Yeah, you can definitely see the blood stasis on the
tongue. Okay. Pressure medication, stable mood. Okay. Okay, and then in terms of points, then I would think you would need the Z-clef points and the alarms. So I would do PC4 and heart 6. And then probably PC6 because that always covers chest.
Yeah.
And then the 2 alarms, the alarms for pericardium and heart would be RIN 14 and 17.
Yeah.
I don't know if there are any others that you can think of. Maybe for the phlegm, we need to do something. So maybe stomach 40.
40. Yeah, I was also thinking that.
Yeah. And
something to help with the blood stasis, to move the blood. So like a...
Yeah. Agreed.
Beta 17 maybe?
Yeah. Yeah. Agreed. I think that's good. I know sometimes PC6 comes with spleen 4, but I'm not 100% sure if that's the right thing to do. But I think stomach 40 and bladder 17, those 2 I would agree with.
Okay. To address the phlegm and the blood stasis.
The blood stasis, yeah. So I mean that makes sense with the syndrome. We need to cover the phlegm accumulation and the blood stasis, and obviously the heart and pericardium.
So our treatment principles would then be to clear phlegm, and blood stasis, and relieve pain.
Blood, yeah. Hold on. So clear phlegm, and then obviously relieve the pain. Correct? Yes, relieve the pain.
Wouldn't relieve the pain be the first one?
Yes, definitely.
Okay.
I'm writing.
Yeah, you're right.
Okay. Okay, so relieve pain first, then clear the phlegm and activate blood circulation.
Yeah.
Yeah.
Okay. Right. Okay, patient advice. That's going to be that A, B, C, D, E probably,
Yeah.
right?
Yeah.
Yeah.
Okay, so it's going to be aspirin and
Beats.
blood pressure monitoring. Monitor blood pressure. I don't know if he's on a beta blocker. He might be because of that heart disease. He didn't know what the medication was.
Yeah.
Yeah.
Okay. And then C, so D is diet. So definitely need to address his diet. So no greasy food.
Yeah.
More vegetables,
balanced.
more balanced.
Mm.
Okay. And E is going to be educate. What was C? So C is cholesterol. So I don't know. He wasn't on any cholesterol medication. I don't know if it's worth saying to him to test the cholesterol.
I would say
All
so.
right, yeah.
Yeah, there's another C, but I can't think off the top of my head what the other C is. Can you think what the other C is? And then E is educate, and there's another E. There's two. There's always
Exercise?
two. Exercise. There we go. Yeah,
Would
so
we maybe suggest, because this has gone from stable into a little bit of more unstable, to get checked out,
Yes, I
at the
think that's a good
hospital
idea.
or
Yeah, that's definitely to see the cardiologist because it's become unstable. Agreed. And then in terms of exercise, I mean, he's saying it's worse for exercise, so I would say maybe not to do that until he's seen the cardiologist.
Yeah.
Okay.
Yeah.
Was there another? With D, there's diet. Was there something else? Oh, diabetes, but he doesn't seem to have.
Diabetes.
Yeah, but that's excluded.
Mm.
Okay.
Did we ask if he smoked?
Yes, I did. He said no.
Okay. Okay, good.
Yeah.
Okay.
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 Was there anything else?
No, I think it's good.
Okay. Right. Do one of you two want to present? Because I have done and neither of you have done. I don't know how you feel about that.
I just missed a little bit of the questions in the beginning when I joined in and out. So I don't think I can do the case presentation
okay.
I can try give
correctly.
it a go, but I just need to organize my scribbles.
No, that's true. Yeah, take a minute to write it in an order because mine's also like all over the place.
Do you want to talk us through us, Celia? If you want.
I'm thinking
So
chief
give us a
complaint.
chief complaint, yeah.
Chief complaint, chest pain for the last 8 years, aggravated over the last 5 days.
Sure, I would agree with that.
Yeah.
Okay. Then for our present disease history, we have 5 days ago or 8 years ago.
Well, 8 years ago, he went to see a doctor about his chest pain, and they diagnosed him with chronic heart disease.
Yeah.
Okay, that's what I would say for that. Then and then you can say he's had intermittent chest pain since then, but aggravated for the past 5 days. And then you could say 5 days ago.
5 days ago, it started to get worse. Okay, wait.
Yeah, chest pain is now more frequent. And then describe the chest pain, that it's burning, it's in the center of the chest, it doesn't radiate, it's better for rest.
Okay, then 5 days ago, chest pain got worse.
Did we ask why? We didn't ask why, what caused it to be worse, did we?
We didn't, so I suppose it would be without obvious cause, even though we know that he has chronic heart disease. I wonder if it's still without obvious cause. I'm not sure.
Hi, Tam.
Hello, Tammy. Tam, I think you're still muted.
You're muted.
Sorry. Hello, sorry, I'm like Doctor Who.
Shame, I had a hectic rainstorm here. It was hailing like crazy.
No worries.
Thank you. I'm so sorry. I totally didn't know there was a meeting. I was fetching my daughter's report. Sorry, guys.
No worries.
Okay, I also forgot because I thought it's every second week, and now that was like a 1 week gap, and I only realized when Celia sent the message. So thank you for that, Celia.
Yes, thank you, Celie.
We'll just catch you up quickly, Tam. It's a case of angina, 58-year-old man, and Celia is just putting the bits together to present it for us.
Okay.
Okay, so
I must
it
just
looks
see
like
I just want to see why my volume is so low.
we can hear you perfectly, but I don't know if you can hear us.
Yeah, I don't know if it's because I had I've just got to figure out what's going on because I can hardly hear you. Let me just quickly see what's happening here. Okay, but you guys carry on, then I'm going to switch off as well, and I'm going to just listen.
Okay, so where did we get to, Celia? You were describing the present.
Yeah, so
symptoms?
I was just saying, so 5 days ago, the chest pain got worse without obvious cause. Pain comes and goes, felt in the center of his chest. It's a burning sensation lasting for a few minutes at a time, but appearing intermittently. Better for rest, worse for exercise or physical work. And he's rating it a 4 or 5 out of 10 at the moment, the pain.
Yeah. Then I would say all the negative things, no shortness of breath, no sweating, no nausea, all the negative.
Yes.
Yeah, no.
So there's no radiations of the pain, no sweating, shortness of breath, or nausea. Was there anything else?
I think those were everything.
I think that's all I've got here.
Yeah. And then, yeah, there was no obvious stomach symptoms, like.
Yeah. So, but something significant was that the diet is quite greasy in terms of the generals. I suppose we didn't ask the question of like currently how is he feeling, but I imagine that picture of the intermittent pain coming and going still stands.
Yeah, and also that the chest pain wasn't affected by temperature, so it's not worse for cold or worse for heat.
Yes.
It's not a cold invasion.
Yeah, and then
and also his mood is stable, so it's not caused by heat stagnation, right? So it doesn't seem to be anger or unstable mood.
So all the generals apart from the diet were normal: mood, energy, sleep, stool, and urination, all fine. And then we did just want to say that he's on medication for his chronic heart disease.
Yeah, and that's an unknown medication.
Yes.
And then he's on blood pressure medication, which he said he takes daily in the morning, but he also didn't say the name of it. But the blood pressure is obviously controlled because if the blood pressure was 120 over 80, 125 over 80, that doesn't seem bad.
And then is it like a is it called a nitrate or the pain?
Nitroglycerin, yeah, I don't know. Yeah, I don't know.
I'll just say medication given for pain, for chest pain.
Chest pain, yeah. Okay. And then obviously the tongue and the pulse needs to come after all of that, I think.
Yes. So we've
I was just about to ask pulse and tongue.
Yeah.
Pulse was slippery and tongue was purple with white greasy coating.
Yeah.
Okay.
Cool.
And then you go on to diagnosis. So the Western diagnosis and syndrome.
125 over 80. There we go. Okay. And also under all the negative symptoms, is that a good place to say he's a non-smoker, or is that
probably, yeah? No, I think I'd put it there. I mean, it could be in past medical history, but I think no smoking, I would put it as part of the, I would personally put it part of the, the things you're trying to rule out.
Right.
Yeah. So past medical history can also normally do no smoking, denies alcohol, denies smoking. Yeah. But in this case, it is relative to the case.
With the diagnosis, we said we were going to go with angina, actually leading toward unstable angina. And then we said that our syndrome, our TCM diagnosis was phlegm accumulation with blood stasis.
Okay.
And then our differentials, we put down good, MI, pericarditis, that's embolism, or embolism. I suppose you could also have like aortic dissection, like we mentioned last week.
Which obviously
and
isn't.
then- yes.
Yeah.
And then so then we move on to our treatment principles. So our treatment principles were to relieve the pain.
Yeah.
Clear phlegm and activate blood circulation.
Okay.
Did he have fatigue, guys? So I haven't
No,
read the whole case. Sorry.
No, he had no fatigue whatsoever. So there was no chi deficiency. There was no shortness of breath, tiredness, nothing like that. No sweating.
Okay,
Then
awesome.
for our prescription, we went with PC4 and heart 6 as the Sheet-Clef points for pericardium and heart. Then we went with PC6 as well to address the chest pain. Oh, and we also did REN 14 and REN 17 as the front move points for pericardium and heart.
Yeah. And then we did point 4, phlegm.
Oh, yes. And then, yeah, stomach 40 for phlegm.
Yeah.
And then bladder 17 for the blood stasis.
Yeah.
All of this would be done bilateral.
Yeah, bilateral.
Correct? Yeah.
Yeah, I agree.
I would think. Okay, so that was our prescription, and then we moved. Well, I just did explain those points with why we chose them.
Yeah.
And then I suppose if our patient advice was the ABCs. So it was aspirin, beta blocker, but I think I imagine he might be on one already, but worth mentioning.
And blood pressure.
Blood pressure.
Yeah, with his chronic heart failure.
Also worth mentioning, there is a family history of hypertension.
Yes.
And then C was for cholesterol. D was for diet. So we need to address the greasy food and suggest the more balanced and healthier options. And then educate
Again, the
and
importance of
exercise.
not eating greasy food, to explain why not. And then, then the exercise to perhaps wait until he's seen a cardiologist, because if he's worse for exercise, we don't want him to overdo it.
So so we'll also suggest that he sees the cardiologist.
Then I'll make a suggestion.
Yes.
I don't know how you girls if you agree or not. What about stomach 36 to tonify the spleen?
Yeah.
What about treating the underlying splenic issue because of the phlegm?
The phlegm, yes.
Okay.
So spleen,
just
spleen 9. Maybe spleen 9, eh?
Spleen 9, yeah, we do spleen 9 a lot in the clinic, for phlegm and damp.
So spleen 9 to go with that stomach 40.
Spleen 9, stomach 40, and then possibly stomach 36 just to treat the underlying root cause, which is the damage to the spleen.
No, agreed.
Stomach 36, spleen 6. Just a suggestion.
No, I agree with you.
Okay. So then I just want to run through the points that we've discussed. So PC4, heart 6, PC4, heart 6, PC6, REN 14, REN 17, and that was more for like the pain. And then spleen 9 for the damp and phlegm together with spleen 40, bladder 17 for activation of the blood flow to help with the blood stasis, and then stomach 36 to tonify spleen to treat more of a root cause.
Okay.
Okay. I think that's good. Do we leave anything out?
Sounds good.
Okay. See, there you go. See, there you already presented the whole thing.
Pretty much.
There we go. That was the practice run.
I think it's pretty done. So that's good.
Okay, thanks, guys. Your patient's back.
Are you experiencing chest pain currently?
You may go ahead.
Okay. All right, so we have a 58-year-old man complaining of chest pain for the last 8 years, aggravated over the last 5 days. So 8 years ago, he went to see a doctor for chest pain when he was diagnosed with chronic heart disease. Since then, he has been on treatment and medication for his chronic heart disease, although he could not tell us what it was. 5 days ago, the chest pain got worse, with occurring more frequently, but no obvious cause was given as to why. The pain comes and goes. It's felt in the center of the chest. He feels a burning sensation lasting for a few minutes at a time. The pain is only relieved by rest. It is aggravated by exercise or any physical work, and he rates the pain a 4 or 5 out of 10. The patient notes that the pain does not radiate. He also reports that he has no shortness of breath, no nausea, is not sweating, and is a non-smoker. When we went through the generals, mood, energy, sleep, and stool are all normal. Diet was a bit of a concern, as he only enjoys greasy foods. He does report being on this medication for his heart disease, as well as a blood pressure medication. And when he gets the pain, he takes a tablet that was given to him by the doctor for the chest pain. But he also could not tell us what medication it is, so it's unknown. His pulse was slippery, his tongue is purple with white greasy spots, and his blood pressure is measuring 125/80. All other vitals were normal. So with that information, the diagnosis was unstable angina, and the syndrome was phlegm accumulation with blood stasis. Differential diagnoses suggested were GERD, MI, pericarditis, or embolism. Treatment principles for this case were firstly to relieve the pain and then clear phlegm and activate blood circulation. The points selected were PC4 and heart 6 as the She-Clef points for pericardium and heart, pericardium 6 to address the chest pain, and then REN 14, REN 17 as the front move points for pericardium and heart. And then spleen 9 and stomach 40 were selected to address damp and phlegm, with bladder 17 chosen for blood stasis to activate blood, and stomach 36 to tonify spleen more at the root. We also discussed patient advice, and these would be the ABC, so A for aspirin, B for beta blockers, which I suspect he might already be on, and to just monitor his blood pressure carefully. C, to check his cholesterol, and also considering how the condition seems to be aggravating, it is worth having a consultation with his cardiologist to monitor the case more carefully. His diet needs to be addressed. We would suggest less greasy food, no greasy food, more fruits, vegetables, and whole foods. We need to educate the patient so that they understand what's happening, and also so that they know that they need to look after their heart and see their cardiologist. And then exercise would be a good thing to consider once he is not experiencing the pain, is in a bit more stable. And that was what we had.
Thank you so much. I think the presentation is quite good, and you provide most of the information we need. Just before we also the treatments and diagnosis, those are correct. So one thing I want to explain more clear in your presentation, but in your discussion you did have just for your presentation. You see, when we see a patient or when you write up the case, you need to just try to imagine what happened to the patient. Just try to make sense. A patient come to you, or if we were the patient, what made the patient to see the doctor? For example, in your presentation, you mentioned that 8 years ago, the patient went to see a doctor for chest pain. You see, this is the cause and results. The doctor does not see the patient does not see the doctor because of chest pain, because the patient have chest pain and then see a doctor and then diagnose. So the flow.
Oh, I
So
see,
what
okay.
so what you need to state with the same information, just try to make sense what happened initially
Okay.
and what happened afterwards. Because for the time flow, for this time flow, we need to we want you to recall exactly the flow, how that happens from the beginning until now.
Yeah. Okay.
So that's what happens. And when it happens 8 years ago, the patient experienced chest tightness or chest pain, and know the severity at that time. The negative symptoms that you mentioned 5 days ago, and these are also need to be 8 years ago on that specific day, because this will determine the severity of the condition at that time.
So, Dr. Hu, are you saying that we mustn't do the diagnosis in the present disease history, only the symptoms?
You can diagnose you can have the diagnosis, but the flow,
with the-
for example, for this patient, is not the 8 years ago, the patient experienced something, the chest tightness, chest pain, no vomiting, no nausea, no palpitations, shortness of breath, no coughing blood, no edema, and no lack of urine. So these are negative symptoms. The patient went to see a doctor, and then they diagnosed coronary heart disease. Because this diagnosis was from the medical doctor, so or from the patient, they tell you in your write-up, you need to put quotation mark to coronary heart disease. No, say you, from the quotation mark, you know this is the statement from the patient. So you can have the diagnosis from there.
But later on, yeah.
Or if the patient went through medical tests or images, you need to write, for example, 8 years ago, if the patient went there, they perform, for example, CTA, they confirm the narrowing of the artery, confirm the diagnosis. So all these you can stay there if they have, if you have evidence or if the patient provide you the report, you can write there. Yes, and afterwards from here, from still 8 years ago now, what did they do? So they prescribe medicine, and how about the symptoms from the past 8 years? How frequent, if the patient have the pain, how frequent does the patient have the pain? How severe? Okay, and from 8 years until 5 days now, during this period, how frequent? What did the patient do if something happens? And now come to 5 days.
Dr. Hu, I just want to clarify. So in this case, you would want to know the negative symptoms when he presented to the doctor 8 years ago, like those symptoms you just mentioned. And then again today, or at the moment, or in the last 5 days, we want to clarify again if any of those symptoms have reappeared. So we would clarify again negative symptoms for in the last 5 days.
Yes, if you think these two are exactly the same, then you can just repeat the more important ones. For example, no palpitations, no cough. If you think these are different, then you need to state differently. Both at both time slots. The reason is because the differential of 8 years ago, you actually tell us the severity at that time. Because for example, if at that time the patient already have acute myocardial infarction, the prognosis until today may be different. Or the patient just have an angina at that time, like mild heart attack. And the prognosis, you see, from this type of presentation, you will know exactly how severe the case was from 8 years ago and now.
Okay.
And I think in your consultation also great, you mentioned most of the important perspective. For example, the location of the pain, the nature of the pain, the cause, the duration, and how to relieve, and all these you mentioned, and these are all important. Just one more thing there is the past medical history. When you, for example, this patient have hypertension and also take tablets, it's under control. How long the hypertension, so the duration of for how many years now. So just clarify these. You don't need the details that the patient have headache, or dizziness, etc. Though you don't need those, but hypertension for 5 years, taking medicine under control, or the range, if you can identify that, even better. So that's, and non-smoker, these are important, the risk factors. Okay. And the symptoms are correct. The differential diagnostics also correct. Just one thing I want to point out, you may already know from the lectures, the recordings, that acute myocardial infarction or angina, especially in diabetes or senior patients, they may not have typical symptoms of chest pain. So even acute or even severe as acute myocardial infarction, the patient may only have chest tightness. So if they have diabetes, this is what happened to diabetes patient is because of the diabetes patient have the nerve damage. So they don't have that sensitive sensation. Even when they feel pain, they don't feel. So it's similar to when their hands and feet, they feel numb. So they may feel even severe. So they may feel just tightness or sometimes even no symptoms. Which means when you see this type of patient or when you see a patient with diabetes, senior patient above the age of 80, you need to pay more attention to those. Just be more careful. And this is also one of the case that I saw a few years ago. A young gentleman, actually 42, at that time, 38. And he suffered from type 2 diabetes and obesity. The blood sugar is always high, and he's a tour guide, so he went with the team. And at that time, what happened is there was one visitor got flu just from China and then landed here, got flu, and then so that tour guide took the patient to the hospital. While waiting, because of the queue there, while waiting, his wife says, "You say you didn't feel well these few days. Why don't you just check while you're waiting here with your clients?" So he went through the process and had blood tests, and then he was admitted. Heart
Sure.
attack. And he has no
So it was
symptoms
like
at all.
silent heart attack. Wow.
He has no symptoms at all, just sometimes chest tightness. And also the chest tightness does not affect his daily life, but his diabetes.
The diabetes. It's a good tip to know that. I never knew that.
Yeah, so this, if you try to make sense of this, it's exactly same as the numbness in the fingers and feet, because
Yeah, the neuropathy.
Yes, when you have the numbness, when you have needles or something to step on there, you don't feel that painful.
Yeah.
Understand?
Diabetic neuropathy.
And also senior patient or senior people, they're also quite common happen to this. So you just need to be careful. And these are also similar to last time when we talked about acute myocardial infarction. You need to be careful just because of age. And the other thing you need to understand is for angina, the grading. For grading, the grade 1 means this is according to the, if I'm not wrong, it's what do they call, the Heart Association of in Canada, their recommendation. So grade 1 means the patient have angina, but the normal physical work does not affect does not limit the patient. Grade 2 means the pain can have onset while fast walking, after meals, in cold weather, or emotional changes. So from after fight with families or neighbors, sometimes the emotional changes may cause the onset. That's grade 2. Grade 3 will be walking. So if the patient cannot walk 200 meters, or the patient cannot walk upstairs for 1 floor, that's grade 3. And grade 4 is like mild movements. The patient may have onsets, or even while resting, the patient have onset. Then you need to pay more attention. So these grading can help you to just to evaluate the severity of when to refer the patient. So for this type of patient, sometimes I will answer, can you walk up floors If you can, how many floors can you walk up? Can you walk up, and or do you need to rest in between when you climb up the floors? Sometimes they say I can climb up, but I need to rest in between. One flight I need to rest. And sometimes, especially here, because many people live on the ground floor, so they don't actually have chance to walk floors. So what you can ask them, from the parking to your clinic, the distance, when you walk to the consultation room, do you need to rest in between? That's to estimate the distance. So this can help you to just to raise the severity, and also the ABCDE. I think you have all those. Aspirin, anti-anginal therapy to relieve the pain. So for this is what's the tablets you use? You put under the tongue. Let me see the English name. You know the one.
Nitroglycerine, but I don't know what they call it. It's
Yeah, the one you put under the tongue. But there's one it's no complication. The one situation you can't use is that tablets will cause blood pressure drop. So you need to, before you use those, you need to monitor the blood pressure. If the blood pressure is low, you shouldn't use. For example, sometimes the patient's blood pressure is at 100 over 80 or over 70. In that situation, you can't use, because once you use, the blood pressure is going to drop to 90, 80.
Oh, yes.
Okay, so that's only one kind of side effect you need to be careful. When we advise, if you have chance to advise patient or to suggest to use, or either to use or to stop conventional medicine, what's most important is the side effects. You must know, because that's the situation you can't use. And B is a beta blocker. Beta blocker as well. If the patient's heart rate is slow, they should not use. So one of the function for beta blocker is just to slow down the heart rate.
Yeah.
Although they can reduce blood pressure control, and cease cholesterol and cigarettes.
Cigarettes.
Yeah.
These diets and diabetes is education and exercise. Okay, and then for the acupoints you mentioned, those are correct. Just be careful if you use those points in your prescription, but in the meantime you still use blood 17 for blood From theory it's correct, but in what position you're going to place the patient if you want to need it. So you just need to be careful these, do you want to use or not?
So in that case, do you then do bladder? Yeah,
spleen
spleen
tank.
instead.
So
Spleen
yeah,
tanks. And also Rome is a 14, the one.
Yeah, we did do
Yes.
run 14 and run 17. Yeah.
run 14 and 17.
And try to use more the influential, right? Influential points. Because those are the connections.
Okay.
And if the case is severe, then you need to refer. Okay, great. That's quite straightforward. I think the information you collected for your consultation is good, and then you collect most of the information just in your presentation, try to restructure. Because if you get used to this type of flow, you can even condense the time in your consultation. Because you're looking for specific information at specific time, and then the duration and another spots and then none.
But it was better than the first case that we did 4 weeks ago.
It's far better.
Yes.
Or last year for our final prep.
Yes.
That Adrian outflanked. I'm still devastated by that mark. It scarred me for life.
Myself.
I'm still traumatized from that crack.
Yeah, myself. I hope the next one won't be like that. Oh, shame. Right. Okay, are we done? It was very quick. Sure, that was fast today, girls.
We're getting better. Sorry,
definitely-
my apologies for being late, Dr. Who. I'm very sorry. I really didn't know we had a meeting. I was fetching my children's reports.
No problem.
Me too.
Yeah.
Anyway, thank you so
Yeah,
much.
And then-
I
Yes.
also didn't realize we have the presentation. Now I check the learning guide and I see the dates.
We must maybe just confirm them next time that we can put them in, because with the kids and stuff, it's a bit hectic. And I hate missing them. I love the virtual cases. So that's why I try to join in rather late than never.
That's why
but
you need mix a few minutes with the consultation so you can have the information
Yes.
afterwards.
Okay, but Dr. Who, will you send us the link again to watch? Then I can just, because I missed a bit of the that I can watch from the beginning and just catch the case properly.
Yeah, definitely.
Awesome. Thank you.
If you have
Thanks
any
so
other
much.
questions, Sidita and Devos, Marie,
No,
thank you.
My
All
side.
good.
Thank you, Dr. Hu.
Okay, great.
In-
Thanks, guys.
Bye.
Sorry,
Thank
just
you.
an observation. Can I just ask a
Bye.
quick question? In
Yeah,
terms
yeah,
of the
yeah.
patients with the grading, would we then say that this person was graded either a 2 or 3 because they were worse for walking?
No,
We didn't
for-
ask. We didn't
for-
ask how far they could walk.
For this patient, you can grade 1 to 2, not
Yeah.
3.
Not a 3. Okay, so 2. Okay, perfect.
And if I can ask a question while we're on that, because we had a very similar case in our prac last year, Dr. Who, when it was relief for rest and worse for exercise. I would have taken that as a bit of a chi deficiency. Is that incorrect?
It can be the combination, but when you diagnose Qi deficiency, you need to
Have the shortness of breath, worse for exertion, spontaneous sweating.
you need to
What's
confirm
severe
with you need to confirm with the town is there any other symptoms, because Qi deficiency will be here but may not be the only reason. Because you see,
And I mean,
when the onset after movements already Qi deficiency was upon movements, but the Qi deficiency may not be the only one and may not be the dominant one. It may be accompanying ones. So you need to exclude all others if you want to diagnose Qi deficiency only, or do you want to diagnose, for example, paralysis with Qi deficiency or something with Qi deficiency. You also need to consider is the Qi deficiency due to other syndrome result in Qi deficiency. So this is why I said if you can conclude into one syndrome, don't use 2. Only if you can't conclude 2, categorize the 2 into 1, don't you use 2.
yes, because that was something that Ange and I remember, Ange, we spoke about it. That's why we thought the chi was a big issue because it was better for rest. So I just thought I must just ask that so that we know that for future.
Yeah.
Okay. Perfect.
Thank you, Dr.
And also you can remember that for the theory we said whenever you have pain, there may be a blockage or maybe malnourishment. So
Yes.
malnourishment and Qi deficiency always together. Lack of nourishment. Lack of nourishment is lack of qi, because the blood is the carrier. The blood is the physical or the carrier of qi.
Chi.
The qi is the commander of blood. So you see these two are together. So if you have blood deficiency, you will have qi deficiency.
Yes, and I was going to say now, if there's blood stasis, that already is going to cause a chi deficiency because there's not flow of there's obstruction. Okay.
Yes. You see, in this way, the qi deficiency may be the result of blood stasis. That's why you don't need to highlight
The
So you
chi
don't
deficient
diagnose,
because it's not.
damp coldness, blood stasis, qi deficiency, because some of these can be the correlate results.
Okay.
Okay.
All right.
Perfect.
Right. Thanks.
So very much, Dr.
Thank
Hu.
you. Thanks, Dr. Who. Thank you,
Thanks.
everyone.
Bye-bye.
Bye.
Bye.